Happy Wednesday, everyone. I'm David Glazer, and I'm here with my colleagues Heather Campbell and Catherine London.
Hello, everyone.
So I'm actually not really presenting. I'm just here to do a couple of quick announcements before I turn the floor over to my far wiser colleagues than I. But I wanted to do a couple of quick announcements before Heather's going to start off talking about 340B pricing, and then we'll move to Catherine. So first, we're taking the month of June off. We've had an extra webinar earlier this year to deal with the fiscal cliff, so June's a vacation month for everyone. July 10th will be a super important webinar on the changes to HIPAA. So for everyone who's worried about the recent HIPAA changes, your chance to get all the details will be July 10th, same time. I believe it's going to be Briar Andreessen and Katie Ilton who will be talking about HIPAA. A thing to keep in mind, if you have not yet started to deal with documents, we have HIPAA templates available. And so there's a copy of the Business Associate Agreement that's available for no charge, a copy of the Notice of Privacy Practices for the bargain basement price of $100, although right now that only incorporates law for Minnesota, Iowa, and Wisconsin. We'd be happy to incorporate other laws in there if you want, but those are the ones that are in there right now. And then finally, the privacy and security rule policies and procedures, which are available for $300. So if you're interested in any of that, there's information on our website. But the webinar will be July 10th, same time, so 1 p.m. Eastern, which translates to 10 a.m. Pacific. The only other important things to note, Heather and Catherine will be happy to take your questions. To type them, type in the chat box on the right side of your screen. If anything goes wrong, like that box disappears, you can often fix that by hovering sort of in the middle of the top part of your screen, and you can find a little tab button, and that will give you your chat box back. Sound occasionally goes kerplunk. People are using the internet to get their latest news stories over the noon hour. If the sound gets bad, use the 800 number that Robert is typing in the chat box. So I think that takes care of our things. I'm just going to introduce really quickly. I don't know how many of you guys know Heather Campbell. Heather has been with Frederickson for a while in our Des Moines office, and prior to joining Frederickson, Heather was a lawyer for a while at Wellmark, so she knows payer stuff really well. And Heather has done many a healthcare transaction and also works in sort of the regulatory stuff. So she's got a broad area of expertise. So we have offices basically in the upper Midwest, which leads people to sometimes wonder, well, can we do stuff in other places? And the answer is yes. We've got clients throughout the country. And so I think we've worked with people in something like 42 states or something ridiculous like that. Also with me is Catherine London, and Catherine is, together with Katie Ilton, the brains that keep us moving and doing things quickly and efficiently and cheap. So I'm going to turn it over to Heather, who's going to talk about the 340B drug discount program. So we'll start with Heather, and then we'll move on to Catherine.
Thanks, David, and thank you all for spending your lunch hour with us today. I know that you have lots of things to do, so we appreciate your time today. So we'll just go to the first slide, which is an overview. And the overview is essentially what we're going to cover today. So I'm going to talk to you about the 340B program basics. And by that I mean, what is the program? What's it intended to do? What is the 340B pricing? Then we'll move to covered entities. Who can participate in the program? And what are the requirements to be a covered entity? In addition to that, what different eligibility requirements do you have to meet? It's not enough to just be a hospital or a different covered entity. What's the registration process? That has changed somewhat since the Affordable Care Act was implemented, and there's been a significant increase in the number of covered entities. So we'll talk about the registration process as well. Then I'll turn it over to Catherine, who will talk to you about covered drugs, which drugs are subject to 340B pricing, which drugs aren't. We'll talk about patients, and that definition is important because under the 340B program, which you'll learn more about today, there's essentially kind of three elements. You have to be a covered entity, you have to provide a 340B covered outpatient drug, and you have to have an eligible patient in order to remain in compliance with the program. So we'll talk about who are eligible patients and who aren't. Then Catherine will cover contract arrangements. And I look at these in generally kind of two broad categories. Since the Affordable Care Act expanded the number of covered entities, there's been, I would say, an explosion of the number of vendors and other providers who are providing different solutions, software and otherwise, to covered entities to help them start, implement, and monitor a 340B program. So that's one side of it. Then the other side of that is contract pharmacy arrangements. So you may have a contract with a vendor to provide software solutions and billing and different things like that, but you also would have a contract arrangement with a pharmacy that's actually dispensing the drugs in compliance with the program requirements. And then finally, everybody's favorite topic in today's world is compliance and enforcement. You might be surprised to learn that we are in a very intense enforcement environment. And so we are getting lots more oversight and enforcement activity in the 340B program than we have had prior. Part of that, I think, has to do with, obviously, the Affordable Care Act and just more covered entities participating in the program. So they're following the money. So let's go to the 340B program basics. What the heck is it? It is a program that was implemented by Congress in the Public Health Service Act. And it is actually administered by, as we healthcare folks know, we're always talking about alphabet soup. So it's administered by HRSA, which is the Health Resources and Services Administration, HRSA, and the Office for Pharmacy Affairs, which is OPA. And we'll often call them HRSA or OPA as we talk about this today. So those are the acronyms, or at least some of them. And what the program does is it essentially requires the manufacturers to provide outpatient drugs to covered entities at significantly reduced pricing. So you think, okay, so what's the point? Well, the idea was to ensure that certain safety net providers, rural providers, and other specialized providers that are in the list of covered entities had access to those covered outpatient drugs at a deep discount, with the idea being that they would be able to use those revenues to continue to provide necessary services for their hospitals their organizations by using the deep discounts to offset other costs. So next we talk about the basics of pricing. The discount applies to any covered drug provided by a covered entity to a patient. So I'm buying the drug and I get the discount. And that's true regardless of the payment source for the patient. So a 340B covered entity can buy these outpatient drugs at the 340B price, and that is true whether or not the patient that the drug is ultimately dispensed to has a third-party private insurance, has Medicare, or pays him or herself. There's no requirement that the covered entity pass that discount on to the payers. Now, there's a slight caveat for that for Medicaid that we'll talk about a little bit later. So the opportunity for covered entities is to generate revenue by keeping the difference between the cost of the drug, that 340B deep discounted price, and what they ultimately receive in reimbursement for that. However, there have been recent questions from our own Senator Grassley down here in Iowa and Representative Cassidy in Louisiana about the program. And specifically, again, in this sort of more enforcement-driven environment and oversight environment, these two congressmen, these two folks, sent a letter to a Georgia hospital that was participating in the program, really inquiring about the hospital's use of those revenues generated from the program and characterized the program really as a vehicle for lowering prices for drugs for the uninsured. Well, as you saw just a few short slides ago, I told you that it didn't matter who the patient was and that the idea of the program was to generate revenue to offset costs in other areas. So there is an organization called the Safety Net Hospitals for Pharmaceutical Access. So another acronym there is SNHPA. And that organization is a membership organization made up primarily of hospitals and other organizations who are eligible to participate in the 340B program. Well, SNAPA is what I call them, got wind of Senator Grassley and Representative Cassidy's letter and immediately sent out a response saying that they appreciated the inquiry, but specifically stated that they disagreed with the characterization of the program's intent, and specifically noted that HRSA and the Office of Inspector General have specifically stated in their program reviews that 340B covered entities can purchase those 340B drugs for all patients eligible under the program, regardless of their income or insurance status, and that the purpose was to allow hospitals the financial ability to serve more patients and provide additional services. So I point this out to you only because it's an illustration of the fact that in this environment, things shift very quickly. And when senators and congressmen in a budget shortfall are looking for areas to look for more opportunities, some of these things get questioned. As of right now, there's nothing to lead us to believe that anything is going to change other than we can continue to expect more enforcement and oversight. But just be aware of this, that the program may ultimately change either from a legislative direction, Congress decides to make a change, or from a regulatory enforcement perspective. So the discount specifics. What is the 340B discount? The manufacturers under the program are required to sell these covered drugs at what we call the ceiling. A lot of people call it the ceiling or the 340B price. The ceiling is a significant discount off the average wholesale price, and depending on the drug, it's estimated that it's between 20 and 50% discount. The discounts are calculated by HRSA on a quarterly basis and involves this really weird calculation that people who don't do math like I don't understand, but basically takes the average manufacturer price, lets a unit rebate amount, and comes up with the ceiling. And that's what the manufacturers are required to sell the covered outpatient drug to covered entities at that price. So that's the ceiling. Then we go to covered entities. So I told you that the Affordable Care Act has expanded the entities that are eligible to participate in this program. And I will tell you that honestly, probably 3 years ago, before the Affordable Care Act, I didn't really know very much about this program. Knew it existed, but not a lot of our clients, or my clients anyway, were participating in the program because they weren't eligible to participate. However, ACA has expanded the eligible entities to include the entities that you see on the right-hand side of your screen. Lots of critical access hospitals in Iowa, lots in Minnesota. So critical access hospitals are now eligible to participate. Rural referral centers, full community hospitals, freestanding children's hospitals, and freestanding cancer centers. So the Affordable Care Act expanded significantly the number of organizations that are potentially eligible to participate. And why do I say potentially? Well, the reason I say potentially is there are some caveats. It's not enough to just be one of those entities. You have to meet some other requirements. So if you are a freestanding hospital, children's hospital, or freestanding cancer center, you also have to have a Medicare disproportionate share adjustment of more than 11.75%. If you are a sole community hospital, you, again, are eligible to participate, but you have to have a Medicare DSH adjustment of slightly less than that, so greater than or equal to 8%. Now, if you happen to be a critical access hospital, you hit the jackpot because you don't have to have a disproportionate share adjustment at all. So critical access hospitals don't have one. The others do have those respective values for disproportionate share adjustments. So more caveats. So you're one of the covered entities. You either do or don't have a DSH adjustment requirement. You also have to qualify as one of these three types of organization, regardless of whether you have a disproportionate share requirement. You have to be publicly owned. Okay, so if you're not publicly owned, you can meet one of the other two criteria. But publicly owned, I just take an example, a county hospital. That would be a publicly owned facility, so that would meet that criteria. Or you could be a public or nonprofit corporation that's formally granted governmental powers by a state or local government. What do we mean by that? So a state or local government has given you levying authority. That would be a formally granted power by a state or local government. Or if you're neither of those things, you're owned by a nonprofit corporation who's under contract with a state or local government to provide indigent care to individuals not entitled to those benefits under Medicare or Medicaid. So for nonprofit hospitals, you're looking at the indigent care, the charity care that you provide. Now, you provide that care today. The question here is, do you have a contract? Are you under a contract with a state or local governmental entity to provide that care? If not, you would have to establish one of those contracts in order to participate in the program, assuming you don't meet one of the other criteria that we just discussed. So entity and you're saying, okay, I'm a critical access hospital, I'm publicly owned, I don't have to meet the DISH threshold, which areas of my hospital can I include and which areas can't I include? Well, you don't need to separately enroll or register any clinics or departments that are within the four walls of a registered hospital. So you register your hospital, anything that's within the four walls of the hospital, you're okay. Now, you still have to meet the requirements with respect to eligible patients and covered drugs, but you're able to theoretically treat all of those areas as a location at which you can dispense those drugs, assuming you meet those other criteria. If you have an outpatient facility or an off-site clinic that's a provider-based clinic, you can register that location if it has been listed on your most recently filed cost report. And that's something I think that has been tripping some folks up. It's provider-based. If it was on your most recently filed cost report, you can register that as a location at which you can dispense those drugs to eligible patients. So when you're enrolling, and we'll talk about registration and enrollment here in the next slide, you have to provide information to support your enrollment. So worksheets A and C from your most recently filed cost report will need to be submitted. Worksheet S2 from your most recently filed cost report if you have a site with a different Medicare number. And if you have a DISH adjustment requirement, you'd have to submit worksheet E. Now, when you're going through the enrollment process, there is a process that will tell you what you need to submit with your enrollment. So some of this may be applicable, some of it may not be applicable to your organization.
Heather, this is just David. I want to just chime in for a second because I know I've heard about places that have not realized sort of the lag that's there on that filing issue and the fact that, because cost reports don't get filed for a while,
right,
there's a delay there. And so...
And we're going to talk about, in fact, we can talk about that right now, but I would just suggest to you, I've got in a few more slides, I would suggest to you, particularly if you are wanting to enroll an off-site location, that you're planning well ahead for that and understanding that you may not be able to do that right away if it hasn't been on your cost report. The second thing would be with respect to that contract requirement. If you're a nonprofit, you're going to have to understand that there's some significant time constraints that you'll need to adhere to get that contract in place that's ready to go on the date of your registration, because if it's not ready to go, your registration won't be processed. And as you can see, as we advance to the next slide, there are limited opportunities for registration. So it used to be that before this expansion in ACA, that ACA expanded, you could register for the program or enroll or whatever you want to call it at pretty much at any time. Now there are some prescribed time periods which impacts your timing if you haven't yet enrolled or registered. There are essentially a 15-day window at the beginning of each quarter for you to register. And it's an online registration process, and the next slide will demonstrate all the things you need to do. But essentially you have a 15-day window in January, April, July, and October. And if you get everything submitted, then you would have a go-live date at the beginning of that next quarter. So, for example, we've already passed the April deadline for a July 1 start. So you could register July 1st through July 15th as the next opportunity for a go-live date of October 1. So if you're not ready with all of your supporting materials for July 1st through July 15th, your next opportunity is not until October for a January 1 start date. So planning is important because the windows of opportunity are small, and then you essentially have to wait another quarter to register. So if we go to the next slide, we're talking about the registration process. Everything today, as with everything else, is online. So you can register online. Again, only during those specified periods can you register. And if you were to go to the OPA website today, it would say registration is closed. You can't register again until July 1st through July 15th. But there is an online registration process that you fill out the information. But in addition, as we said before, you have to submit certain materials with your registration. Well, there's not a way to really upload those into the registration. So you send those documents via email, fax, or courier. And they have different places to send it to via email, different fax numbers, different places to send it to, and all that information is available on the OPA website when you're enrolling. But you'll have to send your cost report worksheets to support which areas and your dish thresholds if those are applicable. The other thing that's important is you have to understand that you have a certification of ownership or operation by the unit of state or local government. So if you're one of those publicly owned places, you have to submit the certificate of ownership, and it has to be signed not only by you, but by your local government official or your state official. So again, that's another piece from a planning perspective that you're going to have to take into account and make sure that that's signed and ready to go when you're submitting your materials. The same is true for the certification of the contract between the state or local government and the private entity to provide that indigent care. You're going to have to certify not only your organization, but the other, the state entity or local entity will also have to sign off on that. You'll have to register your contract pharmacy. So if you have a contract pharmacy arrangement, you have to tell OPA who that arrangement is with, where they're located. And OPA has said that they want this information submitted on the same day that the online registration is completed, which I think makes it difficult because it's not sort of the seamless process. You would submit your online registration. I would probably recommend sending a cover letter saying, here are the supporting materials for the information submitted online on such and such a date for this organization. You know, if you want to get them there immediately, same day, fax, email, are probably your best options as opposed to courier. But it's important that you have all that information ready to go. There's not supposed to be a lag time. OPA has said it won't process. Now, I haven't heard any stories of them saying we won't process it, but that's what they state on their website. So just word to the wise, I would have all of that ready to go. So in addition to the online registration process and all the submission materials, the contract requirements with the state or local government and or the dish threshold, there is a restriction for certain entities on using a GPO to purchase these drugs. And there's been a lot of conversation around this recently. A disproportionate share hospital, Children's Hospital, and freestanding cancer hospital cannot, under the program, purchase their covered outpatient drugs through a GPO arrangement. And this is true even if the GPO price would be less than the 340B price. So, I mean, I guess it's possible to imagine a scenario in which your GPO has such buying capacity and so many organizations involved that you could get potentially a lesser price. They've said, HRSA and OPA have said this is true regardless. So you cannot, which means that the entity can't also have another related entity purchase these drugs through a GPO on its behalf or otherwise receive them. And so I think where you could trip up on this is you have your organization has its compliant 340B program. It's not ordering its drugs through a GPO, and it runs out of something, and it needs it, and it borrows it from an entity that's not participating, but it's kind of within the same family of, you know, parent organization or whatever. HRSA has interpreted this to mean you cannot even receive that other drug. So kind of a tricky situation there. HRSA has said that off-site facilities can participate in a GPO. So this is your provider-based clinic. If they're a different physical address than the parent, they're not registered as participating in the program. So a few slides ago we talked about you can enroll that location if it was on your cost report. In this scenario, if you were wanting to use a GPO at that location, you would not enroll them in the 340B program. It also states that you would purchase your drugs through a separate wholesaler than the 340B participating parent. I think that is going to be a challenge, an administrative burden for organizations. Why would they want to get a whole new wholesaler? And you'd have to maintain records to demonstrate compliance with all of these requirements if, in fact, you wanted to use a GPO for those off-site facilities. So I just mentioned that HRSA published guidance about this GPO restriction, and I think people were like, wow, wait a minute. This is what we have to do. Lots of organizations were surprised, I think, by HRSA's interpretation of the requirements of the GPO prohibition. So lots of folks said, wait, this isn't going to work for us. So HRSA came out and says, okay, if you have GPO purchased drugs on hand, so you hadn't been participating, you bought these drugs through the GPO, they're covered outpatient drugs, now you're participating in the program. Technically, you're not supposed to be able to use those anymore because of the prohibition. If you're one of those organizations to which the prohibition applies, HRSA says, we're not going to make you throw away those medications or otherwise not use them. That doesn't make any sense. You may use those until they are expended, but you cannot make any new purchases under the GPO arrangement after your date of sort of go-live active participation. HRSA's also said it's not okay to replenish or otherwise reclassify your GPO purchased drugs, so no creative accounting with 340B purchased drugs. If you're subject to the GPO restriction, you've got to purchase those 340B drugs using a non-GPO account. So you're going to have to, if you're one of those organizations, what I would suggest to you is start thinking about how you're going to comply with this requirement, talking to your vendor, your contract pharmacy, about how you're going to purchase those 340B drugs on a non-GPO account and make sure that you're complying with program requirements in such a way that you're not losing revenue opportunity there. And usually that involves a split billing arrangement. The deadline for compliance originally, according to HRSA, was April 7th, and there was a great big uproar about that, and so they recently published the guidance saying, okay, we'll give you till August 7th, or as soon as is reasonably practicable for your organization. So if it's reasonably practicable for you to do it tomorrow, that would be their expectation, but the drop-dead date is August 7th. So what's the sanction? The sanction for violation, according to HRSA, is immediate removal from the 340B program. So if they find that you're not complying with that, they can remove you from the program. Practical issues. David addressed, I think, this with his question originally about the cost report requirements. There are long delays in registration of these off-site locations due to the as-filed cost report requirement. If you are subject to the GPO prohibition, you might want to run the numbers and determine whether or not you put that off-site clinic into the program. Maybe you'd be better off leaving them out, depending on what drugs you typically dispense there and what your volumes would be. So careful analysis and planning would be required with respect to those GPO restrictions. And if you're subject to that, be working on that today so that you're ready by the August 7th deadline. The contract with government requirement. The governments generally are going to need to be educated. Educate that governmental unit about the purposes of the program. What the heck is the 340B program? Why do you need to have a contract with them? What are the benefits to your organization and thus their organization to you participating in the program? And again, planning ahead, knowing that you have a limited window of time to enroll and that you have to have these materials ready to go. So you'd have to have a contract in place. You'd have to have those certifications required. And governmental units typically have processes and procedures that require them to do a reading of the contract or an approval over a period of maybe a couple to even 3 times. So building those timelines in and sort of working backward from the date that you plan to register and building in enough time to make sure that you have those things ready to go. It does take a significant amount of time. And now I'm going to turn this over to Catherine to talk about covered drugs and patient definition and contract arrangements.
Thanks so much, Heather. So, as Heather mentioned, the 340B program covers outpatient drugs that are provided to eligible patients. And these two pieces really require further discussion. And so first, with regard to covered drugs, 340B pricing extends to a few key types of drugs. The first being FDA-approved prescription medications. Also, over-the-counter drugs that are written by prescription, biologics that can be dispensed only by prescription, and insulin. 340B pricing is not applicable to inpatient drugs or vaccines. So what does this mean for covered entities? Covered entities are really responsible for maintaining records to demonstrate compliance with the covered drug requirements. And this includes having separate inventories available for covered and non-covered drugs. And it's important to know that some states actually require separate physical inventories be maintained. I think Florida is one such state. But where separate physical drug inventories are not required, the virtual or electronic inventories can help covered entities fulfill their compliance obligations. And I'll actually discuss this a little bit more in the context of contract pharmacy arrangements, where this is actually a requirement. Another thing that's important to know about the covered drug definition is that for certain covered entities, a covered outpatient drug does not include orphan drugs. So orphan drugs are drugs that are designated for use to treat a specific rare disease or condition. And the entities that may not use 340B pricing for orphan drugs include freestanding cancer hospitals, critical access hospitals, rural referral centers, and sole community hospitals. So in 2011, HRSA actually proposed some guidance on this orphan drug exclusion. And this guidance provided that HRSA would allow these specific covered entities to purchase orphan drugs at 340B prices only when the drugs were not going to be used for an orphan disease. So, in other words, these entities that I mentioned in the previous slide could purchase orphan drugs at 340B prices so long as the drugs were going to be used to treat other common conditions or diseases. But they couldn't purchase these drugs at 340B prices if the drug was going to be used to treat the disease for which it received its orphan designation. So this is going to be an area to watch since HRSA has sent the guidance to the Office of Management and Budget for review. Know that covered entities that are subject to the orphan drug exclusion should make sure to keep adequate tracking and have adequate record-keeping mechanisms in place to ensure compliance with this exclusion. Moving on to the next key element in the 340B program requirements. This is an area that's received a lot of attention and has also been the source of significant confusion, I think, for a lot of covered entities. And that's the definition of a patient under the 340B program. So this is a really important issue because 340B drugs, as I've mentioned, can only be dispensed to eligible patients of a covered entity. And patient is not defined by the 340B statute. And so in 1996, HRSA issued a notice that established a three-part test for determining whether an individual would actually be considered a patient of a covered entity. And under this test, an individual is a patient of the covered entity if he or she has first established a relationship with the covered entity such that the covered entity maintains records of his or her health care. So that's the first key requirement. The second one, which I think has generated even more confusion, is that the individual has to receive healthcare services from a healthcare professional who is either employed by the covered entity or who provides healthcare under contractual or other arrangements such that the responsibility for care remains with the covered entity. Now, I want to pause here for a second because HRSA hasn't issued a precise definition of what other arrangements would include, but this is really intended to extend to affiliations that aren't formal, contractual or employment relationships. But it does require more than just sort of loose ties or affiliations between a covered entity and a healthcare professional. And I'll touch on this a little bit more in the next slide, but the third and final part of this test is that the healthcare services received must be consistent with the services for which the covered entity receives its funding or its designation status. And know that this last requirement is not applicable to hospitals. So, what is the takeaway from the HRSA definition? Well, really, the question is whether the covered entity is responsible for the individual's health care. And it's clear that the patient does not need to receive all of his or her health care services from the covered entity, but must receive more than just pharmacy services or the dispensing of a drug. And also note that those individuals who are registered in a state-operated or funded AIDS drug assistance program that receives Ryan White funding are considered patients of the entity and are not subject to the three-part test. So in 2007, in light of some of the confusion and lack of guidance surrounding the patient definition, HRSA actually issued a notice of proposed clarifications to this definition. And this notice, HRSA really narrowed the definition in many significant ways. So, for instance, instead of the current three-part test, in the new guidance, HRSA established about 8 criteria for determining whether an individual would qualify as a patient for purposes of the 340B program. And I didn't include all these criteria on the slide, but just as a couple examples, it would require that the healthcare professional be directly employed by or under contract with the covered entity. So this, under the proposed guidance, it really removes the flexibility of the current patient definition by eliminating the other arrangements language. And that could, could be very significant for certain covered entities, I think. And also, the 340B drugs prescribed under this new definition would have to be prescribed after an individual receives outpatient services from the covered entity, as opposed to the current definition, which requires the patient or the individual receive healthcare services from the covered entity. So those are just a few examples of how HRSA has proposed to narrow the patient definition. And this guidance really received a lot of opposition from the provider community, so it was never finalized. But until HRSA proposes new guidance or releases a new proposed definition, covered entities should really rely on the 1996 three-part test because that will remain in effect. But I think it is still really important to know about HRSA's efforts, and as well as there was a recent GAO report that was released on 340B program, and this proposed definition and the GAO report highlight some of the areas of concern surrounding this patient definition. And specifically, HRSA has explained that has noted that covered entities are broadly interpreting the patient definition to include quote-unquote loose affiliations between covered entities and providers, and also to encompass patients that receive only case management services from the covered entity. And so HRSA, this sort of highlights the fact that HRSA thinks a lot of covered entities are really interpreting this definition too broadly under the current three-part test. So in light of the significant focus that this issue has received, it's really critical that covered entities have a policy in place to ensure that the individuals who are receiving 340B drugs are in fact eligible patients. And this includes maintaining a list of eligible practitioners and also keeping that list updated on a regular basis. And these compliance efforts are really especially important in hospital and contract pharmacy contexts, given that hospitals deliver drugs on both an inpatient and outpatient basis. And as I'll discuss more in a minute, contract pharmacies that see both eligible and ineligible patients must maintain separate inventories in order to prevent diversion of 340B drugs to these ineligible patients. So on that note, I want to move on to another issue that's received a lot of discussion in recent years, and that's the contract pharmacy arrangements under the 340B program. And the next few slides are really intended as just a broad overview of some of the relevant issues concerning these arrangements. But feel free to reach out to me or Heather if you have more specific questions on contract pharmacy agreements, and we'll be happy to provide you with more information on this. So under the 340B program, covered entities are permitted to contract with retail pharmacies to dispense 340B drugs to eligible patients. So covered entities can use these contract pharmacy services either instead of their own in-house pharmacy services or as a means to supplement their in-house services. And HRSA has not placed a limit on the number of contract pharmacy sites a covered entity can use, and this is kind of a recent development based on the guidance that HRSA issued in 2010. And the 2010 notice is really the key guidance on contract pharmacy arrangements, and it replaced all previous guidance concerning these arrangements. So this guidance also defines some of the elements that HRSA expects to see in the contracts between covered entities and pharmacies, which I will touch on more in a minute. But I should also mention, just as a general note, you can find the HRSA notices and program updates on HRSA's website, along with some FAQs if you have some more basic questions about 340B program requirements. So in the market today, there are a lot of vendors that are offering 340B management services for these contract pharmacy arrangements. And these vendors are really promoting their expertise in 340B compliance. They really help maintain relationships between the covered entities and the pharmacies. They'll negotiate dispensing fees and perform inventory management activities, offering to take over the compliance efforts and relieve covered entities of the 340B compliance responsibility. But I think it is critical for covered entities to know that the covered entity remains responsible for compliance with 340B program requirements. And so, in other words, they cannot outsource this compliance responsibility regardless of what other parties are involved or what they claim, what kind of services they claim to offer. So for this reason, it's really important to ensure that a contract between the covered entity and these other parties involved contains adequate indemnification provisions to protect the covered entity from non-compliance with program requirements. And also, it's really important that the covered entity ensures there are adequate mechanisms in place to prevent 340B drug diversion and also duplicate discounts, which Heather will discuss more in a few minutes. So just know that the covered entity cannot hand off this compliance responsibility. And as a general matter, I should note that HRSA has indicated it expects covered entities to conduct an annual independent audit of these contract pharmacies in order to fulfill its ongoing compliance obligations. And this isn't technically required, but it is an expectation, and I think it's an area worth mentioning given the audits by HRSA, which have started to happen now. And so if an audit of the contract pharmacy reveals a violation of 340B requirements, the covered entity is then expected to self-disclose this finding to HRSA along with a plan to address the violation. So I think this is going to be an area of continued focus of the HRSA audits coming up, especially if there are multiple contract pharmacy sites involved. And I think anything that suggests a more complex distribution system could also indicate an increased risk of noncompliance. So it's really up to the covered entity to be well aware of these requirements so that they can ensure compliance. So as I mentioned, the 2010 guidance from HRSA identified a number of contract provisions that it expects to see in agreement between a covered entity and a contract pharmacy. The first is a ship-to-bill-to provision, under which the covered entity will purchase and maintain title to the 340B drugs, and the manufacturers or wholesalers will then bill the covered entity but ship the drugs directly to the contract pharmacy to dispense to patients. So the contract should also indicate that the contract pharmacy will provide comprehensive pharmacy services. This includes dispensing, record keeping, etc. And know that the covered entity cannot require patients to use a specific contract pharmacy, but rather must inform patients of the freedom to select a pharmacy of their choice. And then also, the pharmacy can provide other services, but the contract should specify that the 340B pricing is going to apply only to eligible patients. So in terms of some of the more compliance-focused elements that HRSA expects to see in these agreements, the parties must comply with applicable law. The contract pharmacy should provide the covered entity reports that are consistent with with customary business practices. So this includes quarterly billing statements, status reports, as well as dispensing records. And then, as I've mentioned, the contract pharmacy really must maintain a suitable tracking system to prevent diversion of 340B drugs, and also make sure that there's a system in place to verify that the individuals receiving the 340B drugs are in fact eligible patients. Final two elements here are that the parties must understand that they're subject to outside audits, and this includes by HRSA or even drug manufacturers, as Heather will discuss in a minute. And so for this reason, the pharmacy records must be accessible to these outside parties for their review. And then finally, a copy of the contract should be available to the Office of Pharmacy Affairs upon request. Note that HRSA provided some model contract language for covered entities and pharmacies to use, and that was available in their 2007 guidance. So I think the key takeaway here, if there's one thing you remember about contract pharmacy arrangements, is that the covered entity remains responsible for compliance with program requirements, even if it's using a vendor or contract pharmacy who claims to have expertise in the 340B program. So on that note, I'm going to hand it back to Heather for a more thorough discussion of some of the compliance and enforcement efforts that we will be seeing in the upcoming years.
Thank you, Catherine. And before we kind of move on to address all of these issues separately, I want to reiterate what Catherine said about the contract pharmacies and vendor arrangements. I've recently had some experience in this area in negotiating contracts, not only with vendors, but contract pharmacies. And it's just very important for the organization to understand that, and not saying that the vendors are trying to do anything untoward, but it's very important to understand that you retain that compliance risk. And so addressing in the contract how it is that you're going to address issues that come up in an audit. How is that going to happen? Who's going to take care of it? And if you get into some sort of trouble having to repay a manufacturer or do something with HRSA, are you going to be indemnified for that? One of the areas that has been of significant discussion, particularly when you're evaluating whether or not to even enroll in the program and participate, is it going to be worth it to you? How many of these drugs, how many outpatient eligible patients will you see? And sometimes the vendors will take information from you to kind of look at your patient mix and your employed physicians and other physicians who might meet the definition of prescriber under the program, and run sort of different scenarios. And some of the scenarios are, in fact, I've seen it. One is a sort of conservative, only taking the employed physician approach. The other is a more aggressive scenario that involves employed and professional service agreements, and the third is kind of the most aggressive scenario, in which you kind of have these other loose arrangements, and basically presenting these to the hospitals to say, which do you want to do? Well, the contract itself will typically state that the organization remains, consistent with the HRSA guidance, responsible for compliance, and that it's the organization's responsibility to supply that vendor and or the contract pharmacy with an updated list of prescribers and make sure that that list is accurate and complies with program requirements. So it's very possible that the most aggressive scenario would not, in HRSA's eyes, comply. And so the organization needs to be aware of who it's counting and who it's not counting on that prescriber list. And some of the issues that we're seeing today is maybe some overly aggressive discussions about who is and isn't eligible to participate in that. So just really is something to be aware of when you're evaluating that. And then on an ongoing basis, do those prescribers have that relationship such that whoever they're seeing and writing prescriptions for are in fact eligible patients? So compliance and enforcement, we'll talk about diversion, duplicate discounts, audits, annual certification of compliance, and penalties. So if we go to diversion is the sale or transfer or resale of any 340B drug to anyone other than a patient. So recall, we have a covered entity, we have a covered 340B drug, covered outpatient drug, and we have to have an eligible patient. So if you have everything but an eligible patient and you give it to someone who is a non-patient, that is diversion according to HRSA. It's not permitted. You could also furnish the drug to an ineligible facility of your covered entity. So again, you have an off-site location that you haven't registered as a site for purposes of the program. That would be diversion if a 340B drug was used in that facility. Or you would have a 340B drug furnished for a service to an inpatient, for example. That is not eligible for 340B pricing. So from a diversion perspective, what do you as a covered entity need to do? We've talked about these contract arrangements, and typically there is not a requirement that you physically separate your inventory, but you do need to demonstrate a clear audit trail. So we have to track it by NDC, and you want to track it all the way through the system, which is where a lot of these vendor relationships and solutions come in, because they have the ship to, bill to, split billing software that will help you sort of virtually keep track of that inventory and make sure that when one 340B drug is used, that they're keeping up with the ordering. So you're not physically separating, but there is a very clear system so that if you were to be audited, you could show that throughout that supply chain to the dispensation of the patient that you were in compliance. You also need to consider, as with any other medication, the potential protections you would need to have against theft. I don't know that you would necessarily treat that any differently than you would any other medications, but certainly you wouldn't lock up everything else and not lock those up. So I think HRSA would expect you to maintain at least the same protections as you would for anything else. So then we go to the next piece, which is duplicate discounts. So what's a duplicate discount? Well, essentially, the manufacturers today are required to provide rebates to state Medicaid programs. And because they're required to provide these rebates, there's a potential for double dipping, meaning they might have to provide a rebate and sell the drug as a 340B price if there's not some sort of discussion about which. They're not required to do both. And so the duplicate discount is a process through which you as a covered entity have to either carve in, meaning include your Medicaid patients as eligible patients, or carve them out, saying, nope, we're not going to mess with that. Either way, you have to let the Office of Pharmacy Affairs know when you register and then keep that updated. And the OPA maintains this exclusions file. And what the exclusions file is essentially the group of organizations who have carved their Medicaid patients in. So the state Medicaid agency will look at this exclusion file and say, oh, Hospital X or Pharmacy X is, carved in, meaning that the Medicaid agency will not request those rebates from the manufacturer to which they'd otherwise be entitled because the manufacturer's already given the drug at the 340B price. So that's what the duplicate discount is. Now, you should note that state laws may dictate a particular billing, regardless of whether the provider carves Medicaid members in or out. So regardless of whether or not you carve them in or carve it out, the Medicaid agency may say, you are only permitted to bill us this cost plus this dispensing fee for any Medicaid patient. And that would be something that's independent of the program requirements. That would be the state Medicaid agency's directive to all providers. So you need to just be aware of this duplicate discount, decide whether or not you're going to carve those in, carve them out, and make sure that you maintain that designation on an accurately. So then we go to audits, and Catherine touched on the audits a little bit, but there is a requirement. The covered entity is expected to perform some auditing functions, and OPA really says you ought to have an independent audit at least annually. So again, you want to make sure that your contract with the vendor who may contract with the contract pharmacy or your direct contract with the contract pharmacy adequately addresses the rights to audit, your rights to audit them, and the costs associated with those audits. Who's going to pay for them? When are they going to occur? Who's going to be in charge of them? What are the timelines for responding? Those types of things. Make sure that that's adequately addressed. The covered entities, as you've heard, if we can't harp on this enough, you have ultimate compliance responsibility. So in addition to that, sort of annual audit provision, what other rights do you have under the contract to look at? So, for example, if you wanted to say, I want to see contract pharmacies' policies and procedures on X, would you have the capability in the contract to request that information outside of that audit process? I would submit to you that the answer ought to be yes. Now, I can understand from a contract pharmacy perspective or a vendor perspective, they wouldn't want you necessarily doing that all the time. But there ought to be provisions for that, understanding that there might be times outside of that annual audit where you would expect to receive information if you requested it, and what's the process for doing that? Because if you get audited, you're going to want to be able to show that not only did you have these contract provisions in place, but you actually followed them. So it's the old, we have the contract, but we don't know what it said and we never did anything. That's going to be a compliance risk for you as well. So it's not enough to just put them in. You need to make sure that you're actually doing that. So we move now to external audits. HRSA can audit. So they can, as we said, there's increasing pressure from various sources to improve the oversight of the program. Our Senator Grassley is one. There's a GAO report from September of 2011 that recommended that HRSA conduct selective audits of 340B covered entities. Since then, HRSA's conducted 51 audits in fiscal year 2012. 18 of those have actually been reported on. Of those 18, 2 covered entities were required to submit a corrective action plan. And the reason for that the violation that was uncovered in the audit was not keeping the database entries on the OPA website up to date. So maybe you had a facility, an off-site location that wasn't appropriate, or you needed to pull one off and you didn't do that. So that we can't see what those corrective action plans provide, but just know that those organizations had to do corrective action plans. Again, external audits manufacturers also have the ability to audit under the program. There's a process for them to do that. They have to give you notice in writing, 30 days notice. They have to provide you with information on why they think there's a violation. You can participate in an informal dispute resolution. If they elect to move forward with an audit, they have to submit their work plan to HRSA for review, and then HRSA can decide to take that audit over. And if it does that, it will let you know and let the manufacturer know, and then you're responding to these audit procedures. And what I would suggest to you is, from a planning perspective, plan for this. Who's going to be your audit response team? Where are the documents going to be located? So that if, in fact, HRSA lets you know that you have some pre-planning in place, that you're ready to go from that audit perspective rather than dealing with it as it comes in. And there are increasing numbers of audits right now. We're seeing increasing numbers of audits in lots of different locations. So again, if you're already participating in the program, it might be time to dust off your contracts, make sure that you're doing what you need to do under that from an audit perspective, an internal audit perspective, as kind of a dry run, just in case HRSA decides it wants to audit you. Certification and recertification. There's lots of stuff in healthcare now where everybody's certifying us to everything, and it scares the living daylights out of the executives, and rightly so. In the registration process now and on an annual basis, the covered entities authorizing officials, so your CEO, CFO, someone of that level, is going to certify that the information listed on that 340B database is complete and accurate, that you will continue to meet all the 340B eligibility requirements, meaning you're going to continue to be a publicly owned hospital or have that contract in place. If that's required, you're going to meet your DISH thresholds, that you will maintain compliance with all regulation and guidelines. That's pretty broad. That you have systems in place to ensure your ongoing compliance, that your agreement with the contract pharmacy actually will be performed in accordance with program requirements. So again, not enough to just have all the provisions, you have to actually act appropriately and do what you need to do under those contracts and make sure you're holding that contract pharmacy to its obligations. And as Catherine mentioned, you're required to notify HRSA and OPA of any changes and any material breach. So you're supposed to tell on yourself and what you did to fix it. And I think the piece of that that's important is the material changes. If you have changes, you need to submit those changes. There's an online change form that you can download and make whatever changes you need and submit those. So you want to make sure that you're doing that in real time, or at least prior to any certification, so that you can say that you're, honestly say that you're in compliance. And from a penalties perspective, what's the penalty? You may have to repay manufacturers the difference between the 340B price at which you purchased the drug and what you ultimately should have purchased the drug if there was a diversion issue. That can be really complicated because you've got to go back and figure out what the right price would have been. What we're seeing more of is we haven't seen termination. We haven't heard a lot about termination of participation in the 340B program, but that's definitely a quiver it's actually an arrow in the quiver of HRSA now and what they're telling people they will be doing. There's potential false claims acts. A county in California actually filed an action against manufacturers alleging that they were not complying with the 340B pricing requirements. But there's also, I think, the potential for covered entities to get caught up in false claims acts. Because, again, anytime you're certifying the accuracy and compliance with regulations to the government and submitting claims that may be paid ultimately by the payer, by Medicaid or Medicare, there's the potential for that. So just be aware of that, as with anything else where you're doing compliance and certifications. That's something that you just need to be aware of. And not only do you have to do it when you enroll, but you now have to do it on an annual basis. You have to recertify that you're in compliance. So it looks like we're at the end of our time. We do have a couple of questions that have been put forth to us. And the first one is the off-site facility associated with the GPO prohibited hospital and whether or not that off-site facility can still purchase through a GPO. Can the hospital facilitate that purchase? There's been a lot of discussion about that, and actually HRSA published an FAQ on its website with a question very similar to that. And the answer was that the 340B participating hospitals within a system can have separate 340B registrations. So the hospitals registered for the 340B program as a disproportionate share hospital, Children's Hospital, freestanding cancer hospital, again, those are the ones that have the GPO restriction, conducting price negotiations for covered outpatient drugs with any other hospital would create a prohibited group purchasing arrangement. The hospital system may negotiate prices for inpatient drugs only. So they certainly are taking a very expansive view. I think it's very muddy, but HRSA has very much stated that that's its position. So I think it's very close to the question that was asked, and if it's not quite on point, email me separately, and I can do some follow-up. But HRSA and OPA do have a list of FAQs on their website that address different issues, including this GPO restriction, because there's been a lot of discussion on that. The second one is whether covered drugs can be prescribed for off-label purposes. I have not seen anything that indicates, there's nothing that I'm aware of that states that there is a specific prohibition. Mm-hmm. Now, a payer may, for example, Medicare, Medicaid, or Blue Cross Blue Shield may say, we're not going to pay for any medication that was prescribed for an off-label purpose, but there's nothing in the program that I'm aware of that states that you cannot prescribe. The prescriber is prohibited from prescribing a covered outpatient drug for an off-label purpose. Catherine, are you aware of anything from your...
Yeah, Heather, that is consistent with my understanding as well.
Okay. Mm-hmm. All right, and so that's all the questions that we have, and we're out of time, but if you do have a question, please shoot us an email, one of us an email. Again, we appreciate your time today and hope that you found the presentation helpful. Hope that you'll all sign up for the July webinar on HIPAA. Thank you again.
Thanks, everyone.